We'll just go on to the next speaker. That's the last but not the least, young upcoming surgeon from Center for Sight, Dr. Raghav Malik. He'll be talking about the third hand pars plana instrumentation for the cataract surgeon.
Thank you,
So these are difficult situations wherein we are using the posterior approach to help you for the cataract surgery. Thank you.
Thank you, sir, for this opportunity. So I'll quickly jump into my talk for paucity of time. So basically, what I'm going to discuss is how a cataract surgeon can use the pars plana as a third hand and help in some complex cases. So I'll just start with a quick introductory video.
23 gauge micro incision trocar cannula system forms the backbone of this instruction course. It is imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of 3 23 gauge trocar cannulas, an infusion pipe and 3 scleral plugs. Trocar cannula consists of a sharp spear-shaped trocar threaded over which is a round-bodied cannula. Phakic eye, the cannulas are inserted 4 mm from the limbus. The conjunctiva is retracted slightly and the trocar cannula is inserted in a two-step fashion, initially going parallel to the limbus for half its length and then going perpendicular to enter the sclera. The infusion is secured in the infratemporal cannula. And the superior ports used for the vitrectomy cutter are plugged till further use. It is a relatively simple technique which can be mastered easily with little practice.
So now we'll see some cases how we can use this. So now let's quickly see a case where we all know whenever we encounter a phacomorphic glaucoma or a case of an intermittent white cataract, we know how difficult it is to make a rhexis because the high intralenticular pressure. If we do start a rhexis, we can either do a very small rhexis, or if we try and go into the mid-periphery, it can easily go into an Argentinian flag sign. This is a case where when we try this, you can see how quickly the rhexis runs off, and once we have an Argentinian flag sign, it is very easy for the nucleus to actually just drop into the vitreous cavity. Also, there's a high chance of having choroidals, and this is something which no ophthalmologist wants to see. So to avoid such situations, we can use a pars plana cutter and a trocar cannula. So this is a case of a lady who came to us with a decrease in vision and a high and pain around the periocular area. So this was a phacomorphic glaucoma, and this is how we managed the case. So we did make a port 4 mm from the limbus, and once we go in, so the eye was rock hard. Even after giving a 300 ml of mannitol infusion, the eye was still rock hard, and we were not able to enter inside the eye. So you can see how we can do doing a small vitrectomy from the port so that the pressure from within the vitreous cavity is decreased. Once the pressure is decreased and we can remove some vitreous, you can see now easily we can enter into the anterior chamber. And once we enter, we start attempting a rhexis. Even now, it is not very easy because there is still high intraocular pressure. And once you start a rhexis, we can always keep alternating between doing a rhexis and removing vitreous as required. So very slowly with dispersive viscoelastic, a rhexis is made. We try and not go too much into the periphery. And once a rhexis is made, we're able to complete and we go into the phacomulsification. So phacomulsification is relatively easy once a rhexis is done, and once we remove all the quadrants, you can see at this stage the iris is still coming up from the main port, showing that the intraocular pressure is high. You can see the eye is still again rock hard. Again we come to the port and we remove vitreous, and once the eye is a little soft, we go in and do IA and implant the IOL. We do some vitrectomy from the main port and then implant an IOL and put a suture. One more case. This is a very interesting case. This was basically a patient sent to us. This patient had a trauma with a sharp instrument and actually had a white cataract, and the patient also had signs of retinal detachment. So now what we are doing is we are basically making a port and going from behind the lens so that we can actually cut the base of the vitreous. If we don't cut the base of the vitreous will keep coming as a wick. That's why we go in, make a port, and then cut the vitreous from the base. Once vitrectomy is done from the retrolenticular area, that's when we can go in and complete the cataract surgery and put in a 3-piece IOL. So that's how we want to go in, and if you can see, we want to remove the vitreous from the retrolenticular area. Once that is done, we can now go in and implant an IOL. This is one more case of a patient who came to us with a post-traumatic subluxation of the lens. We do go in attempt of flax. You can see that there is some vitreous in the anterior chamber, and very beautifully we can actually just center the rhexis as desired, and the femto laser actually does pass through the vitreous. So it's very easy to make a rhexis and do some nucleotomy. So this is how we're going to center the rhexis. And once the rhexis is centered and as desired, we go into the rhexis and the nuclear fragmentation. This again, we make a port and we want to remove any vitreous that is coming through the subluxation. We know even while doing the femto laser, we could see there's vitreous, so we know there is vitreous that's going to come out. Once we put Tramsolone, we can see that vitreous is now being egressed. Now, because we've done a femto laser, we do get a free-floating capsular rhexis. And once the rhexis is out, we try and put an ECR before we do any nuclear fragmentation so that the nucleus is actually stabilized. And once the bag is stabilized, we go into a phacoemulsification. Quite easily, we can actually dismember the nucleus and remove the nucleus pieces. And once that is completed, we go in and do the IA. The IA will be a bit difficult because we have the ECR in place, but that's something that we have to deal with. Once that is done, we put in a 3-piece IOL in the bag. And in case we ever find that the lenticular pressure is increasing, intraocular pressure is increasing, we can always remove the plug and do vitrectomy. Now we go behind the IOL and do vitrectomy so that we again cut the vitreous from the base, and so that no more vitreous is coming into the anterior chamber. Once that is done, this is how the post-op looks. Patient was 6'9" on day 1. So this is again a case that was a blast injury from Afghanistan that was referred to us. So the patient actually had a very typical blast injury look, and you can see how this was a post-keratoplasty case. The multiple opacities in the cornea with no visualization, and there was a cataract. So we do use a chandelier system. Basically, it's a system of light that goes into the vitreous chamber, and the retroillumination gives us a very good glow. So this is how the patient looks under microscope light, and once we switch on the chandeliers, we can actually bypass the corneal opacity. So once you put in the trypan blue, and so this is how it looks, and now with the chandelier's retroillumination, we can actually go and do a rhexis, and the visualization is actually very good. And similarly, it also gives us very good depth perception. We can do a nucleotomy and fragmentation of the nuclei. Also, doing the irrigation aspiration is not a very difficult task. This is how the cornea is. We put in a lens under chandelier retroillumination. We put a lens inside the bag. And that's how we can manage such a complicated case with chandelier's illumination. The patient went back very well. He was, of course, 6'18", 6'24", but case was managed very well. Thank you.